Hello to all my dear friends and esteemed colleagues. It is a pleasure to gather with you once more. Today we are here to discuss a topic that promises to be both fascinating and engaging. This subject holds great significance, and I am eager to delve into the details with all of you. These are advanced and cutting-edge modern technologies for diagnosing and treating retinopathy in premature infants, using innovative methods. The topic is very relevant. The relevance of this topic is connected to the fact that recently, a lot of babies have started to survive because the perinatal and neonatal technologies that have emerged greatly contribute to the survival of many premature infants. And this, on the one hand, is very healthy and good, but on the other hand, by surviving, they bring with them into our world many, many different diseases. And retinopathy of prematurity is one of the most serious complications of such survival. It's a complication of such survival, and how to tackle it, how to ensure that a premature baby doesn't face all these vision-related problems and doesn't end up with a disability. In this actually lies our task, the joint task of pediatric ophthalmologists and neonatologists. That's why we decided to give this presentation today. This, in fact, is our task, the joint task of pediatric ophthalmologists and anatologists. So actually, we decided to give this presentation today. In addition, in many countries in the Arab region, due to the active implementation of these survival technologies for premature infants in recent years and decades, we are seeing a significant increase in retinopathy of prematurity. We'll provide the statistics for you below. So, what factors are associated with retinopathy? Here they are presented. You can take a look. Of course, the most important factor is a gestational period of less than 30 weeks and a weight of less than 1,500 grams. Well, 1.5 kilograms. The combination of these two factors usually leads to the development of retinopathy, but there are other factors, and they are listed here for you. You can read them. I won't read them out loud again. All these additional factors that lead to the development of retinopathy are present here. In general, one can certainly think that these factors arise and are related to prematurity on their own. What also happens is that there isn't a clear distinction. A direct cause and effect relationship isn't identified. These factors can also be present in patients with retinopathy. In my opinion, they are also significantly related to prematurity. But the main factors, as mentioned above, are undeniably and unquestionably the key risk factors, and that is, undoubtedly, of course, the influential relationship between the gestational period and weight. Here we see how it varies remarkably and significantly among different regions and nationalities on the path as expressed today. As you can see, recently, in the countries of the Arab region, we are also seeing an increase in this disease. And basically, this is primarily related to survival. On this slide, I would like to show you actually something I believe this is one of the key slides, very important. We know that retinopathy of prematurity occurs due to hyperoxia, which takes place in the incubator, where the premature baby is kept. And so an increase in saturation from 95 to 100% leads to the development of retinopathy. This is a proven fact. And here on this slide, I would like to tell you how to properly perform this oxygenation. Well, neonatologists certainly know, but since we're discussing this topic, I think it's right to come back to once more. An important, probably the most crucial aspect is the first 2 minutes after birth. Oxygenation, saturation should not exceed 55-75%. It should stay within that range, no more. It should stay within that range, no more than 75%. From the 3rd minute, it increases to 65-80. This is a crucial point. If this can be done at the moment of the baby's birth, we can consider that we have significantly reduced the chance of developing retinopathy. In the 4th minute, 70, 85%. I won't hesitate to list what's on the slide because it's important. From the 5th minute, it's 80, 90%. And here's the key point. Oxygenation should be kept within the range of 85 to 95%. It can't go higher. So, 94% is the maximum. That's the limit beyond which you can't raise the saturation. And it needs to be kept in that state. Well, somewhere around there. 90, 91, 92. This is the optimal saturation level in terms of preventing retinopathy. Well, here we're talking about diagnosis. Ophthalmologists know that there are certain zones, areas of damage, areas of formation. These fibrovascular zones where excessive vascularization occurs. These zones are presented here. The first zone covers part of the macula and the optic nerve. The second zone is larger. It almost reaches the entire nasal side from the medial side and doesn't quite reach the level of the ora serrata on the lateral side. And the third zone covers everything up to the ora serrata. In this situation, all three zones are covered. This is, of course, a bad sign for prognosis. Well, here on the slide, we want to show you the boundary of the demarcation line and the avascular zones, the areas of increased avascularization. This is where the formation of the third neoplasm begins. Depending on which zones are affected and how deeply they are affected, that determines the treatment that is applied accordingly. We'll talk about the treatment tactics later. Here, we're also talking about the stages. The development of retinopathy in stages. In front of you is the second stage of retinopathy. You have the opportunity to observe this phenomenon closely. The accompanying text provides a detailed description of what this phenomenon represents and its significance in the broader context. The third stage of retinopathy, when extraretinal fibrous formations substantially increase in the demarcation zone and the retina starts to pull away, leading to a detachment. Here we have the fourth stage of funnel-shaped detachment. Overall, this is already a severe condition. The difference between stage 4 and stage 4B is that in stage 4, we can still see the optic nerve during ophthalmoscopy, while in stage 4B, we can no longer see it because changes start to occur in the feet. Closure of that funnel. And the fifth stage is changes in the anterior segment of the eye in the front layers. This is already the outcome, the complete outcome of this disease. On this slide, we have the vascular characteristics in the posterior segment. The text again mentions that we wanted to show the actual image of the fundus, highlighting what to pay attention to, like the dilation of the vessels and their tortuosity. This is how we conduct patient examinations in a detailed and thorough manner at our clinic. In a state of medication-induced sleep, this definitely happens, as you can see. The studies we conduct are also described here. In older age, as well as in younger age, we can also perform visual evoked potentials during sleep. Well, during sleep, it's clear with the flash, and for younger children, and for older ones, we start doing it with the checkerboard pattern and on a strip with a rectangular light profile. We do this to understand what the patient's visual acuity is. An important point is also the MRI because, as you remember, when we showed the changes that occur in premature infants, they can be related to brain pathology, including hyperoxia, which can lead to changes in brain structures. So, doing an MRI for these kids is also important to identify any changes in the brain and to carry out appropriate treatment together with a neurologist. This is very important in terms of prospects. If we manage to control retinopathy, then to ensure a good quality of life, we definitely need to work with neurologists in parallel because, as a rule, These children often have lost neurological disorders as well. One of the new things that are increasingly and gradually being introduced into the clinical practice of more and more countries today is the use of artificial intelligence for diagnosing various different diseases. And the retinal is almost not there, also right there. It's involved in this diagnostic process. Changes in the blood vessels are being compared on the main fundus in premature infants, and accordingly, artificial intelligence can diagnose the stage of the disease, whether intervention is needed or not, whether to start injections of vascular growth factor inhibitors or some other intervention. In general, artificial intelligence is gradually coming to us as an assistant in managing patients with retinopathy. Well, the treatment is, of course, related to what stage the patient is in, how it's progressing, how often we need to monitor it, how the disease develops, and what methods to apply. Until recently, laser coagulation was used for this avascular zone. In the last few years, they have also started using vascular growth factor inhibitors. It's very interesting in itself and less traumatic. Well, there's a certain approach that many ophthalmologists, if not the majority, share, which is that these two treatment methods should be combined. Both are used. From your side, I want to say that the use of laser coagulation always results in high myopia afterwards, and there are always serious problems with the subsequent development of myopia, strabismus, and all sorts of other issues. In my personal opinion, it definitely makes sense to use a combination with laser coagulation if we have rapidly progressing process. In case there's something new we're already at the second stage, while we're still only at the first stage. And if we want to do prevention regarding the decision to intervene, there are a lot of factors that need to be considered. This is primarily the relationship, as we already discussed, between gestational age and weight, and then the development of the erythropathic changes in the fundus. The rate of progression of these changes, the previous history, how the child was introduced to oxygenation, and in what way. And based on all this, a decision about intervention needs to be made. The most effective, on one hand, and on the other hand, very gentle and minimally invasive, is the use of intravitreal injections of vascular growth factor inhibitor drugs. That's a long list. It should be applied based on taste and availability. How and how often, that's probably a topic for a separate lecture. But the fact that they are very effective has been repeatedly confirmed by us and many other authors as well. And here's one downside that all the supporters of this approach related to combining coagulation and intravitreal injection talk about. This is because often intraventricular injections lead to certain changes from the outside, not just on the eye tissues, but they also affect the overall condition of the patients. Well, again, it seems to me that this is also something that requires further study because the doses used are very small and they are applied very locally, you could say almost topically. I think we need to continue these studies and find the answers. If it has an effect, then what amount of injections has an effect? What doses have an effect? And if they don't have an effect or have an unreliable effect, then we need to be told about it because local effect is really good. And I wouldn't want us to apply this laser coagulation based on some unverified or not fully verified studies because it causes very significant side effects. Earlier, I mentioned that there are some other factors that also influence the development of retinopathy aside from weight and gestational age. This is one of them. It's a human-like insulin factor that can be used together with the appropriate protein It says which one to also stop and prevent the development of retinopathy. These are some of the main directions today, in addition to everything I've already mentioned. Well, genetic therapy is also being developed in some laboratories. It's believed that there are certain factors related to a specific predisposition in some newborns, particularly premature infants, that make them more likely to develop retinopathy. To be honest, we were talking with colleagues when we were preparing this report, and I was given these materials regarding gene therapy. I'm a bit surprised actually, because the main factor here is prematurity itself. But if there's kinetic therapy for prematurity, well, that would be really great. We know that today's genetics is making its way into all areas. But if there is kinetic therapy for prematurity, well, that would be, of course, very cool. Well, we know that today's genetics is making its way into all areas. Well, in any case, something interesting will probably come out of this. Here, I would like to show patients who we help the patients. We managed to prevent them from going blind. They didn't become disabled, but still, they develop certain pathologies, right? Because depending on how deeply their retinopathy developed, there can be different situations. But if it's, let's say, laser coagulation and then rapid development of myopia, then that's usually amblyopia. This isn't strabismus. It's strabismus, cataracts, and a lot of other issues that arise. What treatment options do we have for these patients after retinopathy has developed, once we've managed to control it and stop its progression? How can we help these patients? This is surgery for non-strabismus strabismus, and it's cataract surgery if it occurs. The most important and common thing we have to do is therapy that helps us improve and maintain vision in these patients. Regarding strabismus surgery, I want to tell you again about our Strabo program, which allows us to perform very precise surgeries on the eye muscles, including for these patients. It's based on an equation, a trigonometric equation, that allows us to very accurately determine the amount of correction needed for the angles of alignment by inputting the corresponding patient data. The effectiveness of the method is high. Usually it's a calculated range from 0 to 5 degrees. The difference in the position of the eyes that we get, but there are about 3 to 4% of patients, especially adults, for whom the effectiveness of such calculations is lower. And this is usually related to the reasons why strabismus occurs in this group of people. In adults, I mean those over 40, 50, usually there are some endocrine issues or neurological ones. When it comes to children, the effectiveness of such calculations is very high. This surgery that we use is minimally invasive. In fact, the muscles aren't damaged, and everything heals very carefully and quickly. We use a fine suture material, and we use radio wave instruments instead of regular scissors, as is usually done. Here are our patients before and after the surgery. Vision therapy is a very important aspect of treating patients in general, and particularly those with the consequences of retinopathy. It allows them to achieve stable, good vision, which enables them to actively participate in the learning process and in their professional orientation. In general, vision therapy is everything for us because right now we are implementing this vision therapy in Bahrain. Since this is a new thing here in Bahrain, and people aren't very well informed about its endless possibilities, I just want to personally recommend that we more actively refer patients for this type of treatment, because it really is effective in a number of cases. It's effective for treating amblyopia, it's effective for stabilizing myopia, and it's effective for developing fusion, teaching the patient to use both eyes, especially for patients with strabismus and nystagmus. This vision therapy is effective in developing stereopsis in patients, allowing them to see in 3D format, especially in patients with different vision in each eye, where one eye has better visual acuity than the other. In patients with strabismus and in patients with nystagmus, and also after cataract surgery too. Treating amblyopia isn't just about the occlusions we do, but also involves a whole range of other comprehensive methods. Here, I should mention that amblyopia varies. If amblyopia is refractive, meaning it's related to an optical defect, then it's definitely easier to treat. If it's obstructive amblyopia, meaning it's related to cataract, then treating that kind of amblyopia is more challenging. If amblyopia is refractive, meaning it's related to an optical defect, then it's definitely easier to treat. If it's obstructive amblyopia, meaning it's related to cataracts, then treating that kind of amblyopia is more difficult. Congenital wounds and acquired myopia are also difficult to treat, but this complex treatment increases the effectiveness many times over. It is complex many times over. Vision therapy treatment allows us to effectively combat amblyopia. A patient with strabismus, we've already talked about how we need to teach the patient to merge images. Two images on the left, on the right, a single image. In such patients, this function is impaired. And it never develops because during the sensitive period in early childhood, their visual system didn't work well. And here, restoring these reflexes, activating these reflexes is the task of vision therapy. There's no other way to do it. The only way is vision therapy. Well, friends, I think I'll wrap up our meeting today. Thank you very much for coming. Thank you very much for your attention. I hope you found all of this interesting and informative. We are always at your service. Crystal Vision in Bahrain is open specifically designed to help our little patients. All the best. See you next time.